also remember Don's generosity of spirit after losing Kristen in the 90s to a sudden illness. That memorial there was established in Kristen's name on behalf of Don and his family, and it continues to bring comfort to many of us. Much thanks to Dr. Schaffner for whom the lecture is named and who we honor today by being here. It is a distinct honor to introduce to you a very colleague of mine and a very special speaker, Dr. Klin. Klin, who is Georgia Research Alliance Independent Scholar, serves as the director of the Marcus Autism Center. He's a professor and chief of the Division of Autism and Developmental Disability at Emory University School of Medicine. On his PhD from the University of London, he completes clinical and research postdoc fellowships at Yale Child Study Center at Yale University School of Medicine, where he also directed the autism program until 2010, when we were very fortunate to attract me here to Atlanta. You all probably know this, but Dr. Klin is an internationally recognized clinical psychologist and researcher in the field of autism. And he's going to speak on how developmental social neuroscience meets the public health challenge. So please join me in welcoming Dr. Klin.
Thank you so much, Anthony. Good morning. Thank you for being here so early in the morning, and it's a privilege, an honor to be here for the Dr. Schaffner lecture. And I took an opportunity to learn a little bit more about Dr. Schaffner. So my hope is that the theme of this lecture is consistent with his life mission. Dr. Schaffner actually reminds me of another Donald Cohen, the person, my mentor, who was one of the pioneers of clinical services and research in autism. And it takes those two Donalds to tell me that there is a wonderful mission that we operate in really using and leveraging our very best science to address the challenges faced by vulnerable children and their families. So thank you for your generous introduction, Dan. The Marcus Autism Center is the largest center of its kind in the country. We serve over 5,000 children a year at the center, and another 14,000 children in the community these days. We're also a very large center of science. We're one of the only 3 National Institute of Health Autism Centers of Excellence. And we train people in the center, we train people in the community, not only through formal internships and residencies and fellowships, but a big important thing for us is really being a catalyst for change in the community. And most of our training actually happens these days in collaborations with the Georgia Department of Public Health and with the school system in Georgia. We really would like to be part of a solution that brings the entire community together, because the challenges are quite Press there. Excellent. So, a few minutes about autism. Autism is the most common form of neurodevelopmental disorders. 1 in 68 children. We're talking about over 4 million Americans with this condition. And so it is more prevalent than all childhood cancers, juvenile diabetes, or all childhood HIV put together. The societal cost of this condition is huge. It's in excess of $130 million a year in the U.S. alone. And I think most importantly, the number of lifetime cost of care and loss of revenue for a family who has a child with autism is in excess of $2 million. Despite all of those challenges, we have some really low-hanging fruit in our field. Autism is the quintessential neurodevelopmental disorder, which basically means that the onset of this condition is very early on. And much of what we actually think today as the greatest burdens of this condition, the intellectual disability, the language disability, and the severity of the challenges, these are things that develop with time. We're used to be able to identify this condition early and provide children with the services. We would significantly attenuate those burdens. And remember that autism is a lifestyle condition, which basically means that the things that we can do for children, really capitalizing on neuroplasticity that exists in the first 2 years of life, those are gains that will be there with the child, with that family for the rest of their life. We have a wonderful severe behavior treatment program at the center. It costs in excess of $1,500 a day for a 60 normative processes that every child has to go through in order to survive in this world, meaning to communicate with others. And so we have an immediate connection between genes and symptoms. What it does is that it disrupts normative socialization. The results that are the behaviors that we now call autism. So it creates an enormous opportunity for us because in the first years of life, we have all of that neuroplasticity that we can capitalize on. And in fact, were we to be able to normalize those experiences here, well, we would have completely different developmental trajectories for these children. So we don't believe in this genetic determinism because it's a very small minority of children who truly have monogenic and highly panic conditions. Vast majority of children in autism, this is a highly complex polygenic condition using, really involving common balance. And then probably balance that we look at yourself. So that's a great opportunity. In my field, when I started in this field, I started working with adults in a residential that serves individuals who had spent all their lives in long-stay hospitals. All of those individuals were profoundly disabled. For the past 10 years, 12 years, we have accompanied babies from the time that they're born, monthly, and we see the evolution of autism as it happens in the first years of life. And I can promise you that this is a very different condition indeed. And that ability of development that we see early on is quite extraordinary and provides us with a tremendous opportunity. We also saw this is the brain, isn't it? So there's very little to be done. Now 10 years of neuroscience, the brain not only determines where we're going to be, the brain also becomes who we are. And those early experiences in this kind of iterative process, not only the brain specialization is impacted by early experiences, but it's a process that moves on in those iterative processes all the way through the development of communication, which is the big prize for us. So we don't see also brain determinism in our field. And here are the three concepts that I want to make sure that I speak to. Our cancer focuses on those very early emerging, highly conserved mechanisms of socialization, things that babies bring into this world from the first days and weeks of life. So typically they prefer to orient to things that are social in that environment. Speech sounds like their mouth is speech, or they love to look at people rather than at things. And as they look at people, they love repeat life. And that, in a way, catalyzes the occurrences of this baby into this mutually reinforcing choreography with their caregivers. And the nature is kind of very, very wise because at the same time that you solve the problem of survival, a baby will not survive with their caregiver. What happens is that social interaction also becomes a platform for brain development. And we need to remember that really babies coming into this world ready to learn, but their brains really are going to change dramatically in the first years of life. In fact, by the time that babies reach the second year of life, the end of second year of life, they have 200 to 300 more synapses that we adults have. Of course, what we see is that pruning process that really reflects specialization. So this is the time that we need to capitalize on. One important thing that sometimes that we tend to forget is that some of the concepts that I'm telling you now that I found into the field of autism, children with autism have a social disability. They come into this world with an attenuated sense of the other. Some of those principles actually are principles that are universal. We are often concerned about children that come from disadvantaged backgrounds or low-income families, or they have other complications. Children who are DQ graduates, or who have congenital heart disease and spend 2 or 3 months in a hospital. Well, if this is the platform for brain development, any disruption that happens in that process can have consequences for the children. And it's important for us to know that the way that nature works is that you cannot put a child in front of the TV and the child's going to learn language. There has to be an engaging person on the other side. But what is really nice about this process is that if this is so, that we can actually enter an environment that is going to promote that. It's not going to be, millions of dollars for us to enact a particular kind of a treatment modality that requires the Stuff you remember. Oh, yeah, you have to put those things. So this is a beautiful 50-month-old little girl who is doing something that is entirely different from her peers. She basically is in a world of her own. I am 2 inches from her nose, and basically it is as if I did not exist. So all the principles that I've mentioned to you, her way of looking at the world is very different indeed. Now, 5 minutes later, she does this. Up. Up. The reason I have this video is because at the time, this was the youngest child ever diagnosed with autism at that year. Nowadays, we have a randomized controlled trial that begins at 12 months of age. So this is all past. At the time, there was a veil of mystery over the early childhood of children with autism. But what she's showing here is that the way she came into this world, rather than falling in love with people, she's falling in love with objects. This is an M&M that she saw 5 feet away, even though she couldn't see me 2 inches from her nose. Now, imagine that she's creating her own niche. She's interacting with a world. Her brain is becoming specialized, is learning about things other than all of those elements necessary to interact with peers, to develop the understanding of people, to develop the understanding of things such as mental states, like thoughts and feelings and intentions and things of that nature. So she's taking very different paths. In fact, sometimes when we interact with adults with autism, we try to think, my goodness, those individuals, many of those individuals can be brighter than you and I, and they have those expertise, but they have expertise in maybe things rather than people. And so it took many, many years to try and go back in time and try to find the origins of that stuff, which also becomes a tremendous burden, because for almost everything that you need to do in life, to independently, to have a vocational opportunity, and to truly have meaningful relationships, well, those skills are obviously necessary. I say that most of the funds that are associated with autism, we talk about $130 billion a year, most of those funds, they go to support adults with autism who have intellectual disabilities. So we have a big challenge in our hands. As a clinician, I remember walking into my hundreds and hundreds of evaluations of children, adolescents, and adults, and this resonates together. This is what we do as clinicians, right? We use bodies as laboratories of social engagement, and we want to feel other in the same way that the other is feeling you. Well, all of those experiences make you feel like, my goodness, that isn't that kind of resonance, but can elevate you to satisfaction from a close subjective experience to basically quantified stuff. So my colleague and I, Warren, Joe, for many years have been using eye tracking technology in order to measure moment-by-moment engagement of individuals, including babies, with the world around them. And so there's a 5-month-old who is basically looking at a caregiver, speaking to her, to him in this fact, here. And at the same time that the baby's doing that, we're measuring 500 times a second. What is that baby entraining to or reacting to? One of the big issues for us is, of course, that social interaction, this is the platform brain development side, didn't I say, is that it's so hard to measure those things because there are hundreds and hundreds and hundreds of things happening all around us, right? And somehow our attention is catalyzed. Jennifer Staple actually here likes to talk about one of the main reasons of the work that she does. Say, for example, talk to me babies, sort of teaching pregnant teens and multiple mothers about the importance of engaging and talking with their babies. And we talk about the 30-minute work gap, the fact that by 3 years of age, some children coming from low-income environments have been exposed to 30-minute work less than the upper middle class appears. Well, we have to take it on because we have measured the change in the facial features of a mother interacting with the baby at a rate of 8 times a minute. There are changes of facial features. And those are the kinds of things that a baby really needs to truly understand the world. Now, if your world is not evolving that, and you can think about minutes turning into hours, we have a very significant facial experiences gap in our field. How is your brain going to specialize? We need to get a sense of that. We need to magnify that. So if this is really the platform of brain development, we really need to be able to the way that children in kind of experience. Well, you learn about intentions, about emotions, about conflict, about communication, about being stubborn, about a whole bunch of things. This is really what the battlefield for understanding that. But how can we measure that? Okay, imagine that this video is something that we present to 2-year-olds, okay, typical kids and kids with autism. Now, we have to measure it. So imagine this is a frame. There are 30 frames per second, okay? And so this little equation here, this equation is basically models the resolution of the image for a child who is looking at that spot of the screen at that moment in time. It's basically based on the amount of photoreceptive cells that are basically dedicated to that spot. You know, as you move through the periphery, there's sparsity of those cells. So look at this as basically one individual looking at that spot of that screen, the amount of visual resources that are being dedicated to that. This actually translates into core magnification, which basically means the amount of brain tissue that is associated with processing that. Now imagine about 35 2-year-olds looking at that spot of the screen, and what you see here is an additive effect. And the bright color tells you that more children are looking at that particular spot than, for example, over here. Is that clear? Now, remember that this is a frame of video. Now, let's take a sort of a bird's eye view. And what you have now is this screen, and you have what we call a mapping of salient. The big red, sort of big red here, the hot color tells you that our kids are paying attention to that. Now, what we can do is basically watch the same video that we watched before through the eyes of 35 typically developing kids. So, something's happened, nothing very important, and all of a sudden, maybe, something really happened there. Can you see? This is basically a space-time distribution. We can now watch that video through the eyes of those children, which basically means what was important to them. And when nothing is happening, there is this dispersion of attention. When something really critical, we call them the hot spots of socialization. There is an attentional funnel, and there is a convergence, and we see this in hot colors. Now, let's take now a different view. So this is a frameless video, and this axis here is time. And what you have here is basically the brain. Let's carve basically this salient, the map here, and see what we have. Now, what we have is a space-time distribution. Those are the funnels of attention that I just mentioned. Here, there is a tremendous dispersion, nothing happening, and here in red, something really important happens. Remember that these are moments of social experience for these children. These are the moments that are creating this synaptic growth and specialization that we talked about in the beginning of this talk. Now, we can see the space-time distribution basically unfolding in time. And so, even though there's enormous complexity in this scene, this is where the children are paying attention to. Moment by moment, they are focusing on those aspects that make it possible for them to understand what is going to that. have clinically when we interact with individuals with autism is that we have to have a shared context, a background, because our experiences have been so different. You know that when we're talking about us, we basically build on a sense of the world. We build on the sense of a whole bunch of pieces of information that make it possible for us when we are communicating with others to be understood. We don't need to say everything. There is something called pragmatics. There is something called context of world that everybody knows. Well, everybody knows because we share the same culture. So here we have moments of enculturation. The reason why we are able to do so is because the children are really a great program internally to seek same kind of experiences which result in a shared worldview. Now, what happens with the children with autism? This is a notice file. This is the frame of the video. Here, what you have now is basically this scan pad on 2-year-olds with autism. And so, what the typical kids are focusing right over here. This is where our kids are. So, at the moment in time, they are diverging from that experience. Okay, and this is where the typical kids are looking at, and this is where the kids with autism are looking at. A door opening and closing. Okay, things happen hundreds and hundreds of times. Hundreds and hundreds. In the context of 5 minutes. Take a look here. These are typical 2-year-olds. Here are the 2-year-olds with autism. And you see that experience they are having is quite different from the experience that this is having. And I have to say to you something, that there is a happy ending in that movie. That's cute. This is what the typical kids are. This is the culmination of that important of experience. This is where our kids with autism are. So they teach the same thing, but they divide the divergence is so dramatic that they basically experience something completely different. And the brain is really deaf and blind. There is no theoretical information over there. It only impacts brain if it is experienced as such. Now, those kinds of divergences, they happen 10 times during a point of, a 5-minute experience watching the video. But those divergences in experience don't happen only within our assessment. They happen at moments of their waking life as they are interacting with the world. So when I go with Jennifer to talk to people and say, we need intensive intervention in our field, is because our children, moment, are diverging from the experiences that are going to lead into autism. And the more it takes for us, the more expensive they to be later. On the hand, if we're able to normalize those experiences, then, well, that's kind of the limit. All right. Here is something that we learned. We call this a measure of relative entrainment, because every time that we have a normative funnel like this is our children with autism. Okay? And it basically sums all of those divergences. And so this is just a little bit of data. Today I mean scarce data, but I'm happy to show you that. This is the 5-minute experiment. These are clinical measures taken at the same time at the age of 2. And these are clinical measures, standardized clinical measures, taken 1.5 years later. Our 5-minute measure basically concurrently predicts, level of social disability and level of cognition, including language. But 1.5 years later, he predicts very strongly level of social disability and very strongly language. Why? Because that process that I just mentioned to you is the process of social learning. We learn about the world through others. If children are diverging so much from the experience that we teach to learning, this is going to basically predict the level of intellectual ability. So the intellectual disability that we've been living with for many, many years in autism is something that we can predict and thousands of children who are safe from having intellectual disabilities because we detect this early on, PKU. Or it's not unlike PKU. $130 billion a year in the U.S. alone will tremendous, potentially devastating conditions for child families. So this is very exciting. Now, if this kind of bit of science that I'm just exemplifying to you today, does it have any translational about it? One of the big issues that we face all the time, talking to the commissioner yesterday, we can try and engage the whole community university screening, and we want screening to basically translate into services. Absolutely. There's a little bit of a gap in between, and that gap is called diagnosis. That's a real issue. It's a real issue because diagnosis is really the key for services. But the number of clinicians in the community of expert clinicians is minimal. And so I mentioned to you that the median age of diagnosis in the country is 4.5 to 5.5. Okay? Among minorities, low-income families, we lag still by 5 years and a half or so. There are whole sectors of our community that will definitely have the children with the worst outcome because of lack of access. Well, we could sort of train hundreds and hundreds and hundreds and hundreds of expert clinicians to conduct diagnosis in this field, or we need to find another way. And we thought, can we leverage the science that I just exemplified to you and make it possible for us to augment access to diagnostic services in the community? So we took our lab that we've been working for many years and translate and transform it into a device. And the idea is to create this low-cost, high-throughput deployment of a performance-based, quantitative measure of social disability, including for the diagnosis of autism. So autism can be as devastating as child cancer, truly. I mean, come to our center. I have sort of the father and the mother of a child with autism, and I come to a doctor, and the doctor puts in my hand a paper and pencil questionnaire. How would you feel if you went to ask like people do that? We shouldn't feel like happy, right? Well, we're not very happy with the state of science in our field either. So we need to elevate it. We need to have quantitative measures. Yeah, idea. So what we did is we created this prototype, and what we would love to is to deploy it to the community. And we've been doing so. In fact, this prototype has been running as a foresight this life for children over there for the past year and a half, almost 2 years. And so we had some compact publications that led us to basically an opportunity to test this device as a diagnostic device. It's now we haven't started quite yet, but it's going to be an FDA-registered pivotal clinical trial happening in 7 different sites, including Seattle Children's and Cincinnati and so forth. And what kind of data we have for this device so forth? Remember, it's supposed to provide us with a 10-minute procedure that is going to be low cost and approximately expert clinicians. That's what we want to do. So this is a slide about a year ago now, but we had about the data on 326 toddlers. And these are toddlers between the ages of 16 and 30 months, primarily 18 and 24. And the reason why we're focusing on that age is because that's where the babies come for the well baby checkup. And we want something that we can work with primary pediatrics and make it easier for children to be seen, to have a quantitative measure will allow for basically action on developmental delays and autism. And these are But the problem is this: if this is the platform for brain development, one of the big issues that we have is that diagnosing children creates an enormous bioethical challenge. If we are not capable of going alongside that effort to augment access to services, what would we do? I'm going to talk to our pediatric physicians, come and say, well, we can identify the problem, but there's nothing that we can do about it. Okay? So say, the core message here is that we're putting equal amounts of effort and energy in augmenting access to early treatment. And here is the thing, mentioned that only 1 in 5 of children are identified before the age of 3 years. Those who are receiving special education later on, I told you that our children are digging moment by moment from the normative experiences that their peers are having. How in the world are we going to be able to achieve the level of intensity required in those treatments? Imagine if I were to say, here's the treatment. I'm going to take somebody who costs a ton of money, okay, and I'm going to deploy this person for 25 hours a week working with your child. Well, in the words, if you're one of the 1 in 5 that gets identified before the age of 5, how much are you going to get? 2 hours a week. So how conquer this little problem, right? If you saw that autism is basically unfolding right in front of your eyes, and here really is the answer. Is that we need a family engagement so that we can work with partners in the community. And, Dr. Amy Weatherby likes to say that, there are 3 pillars, a little bit like 3 wheels that need to go together in order to make this happen. No one is a medical home. Absolutely. That's the gatekeeper for all that happens for children. One is the families, because without family engagement, we ain't going to get anything going. The third is our partners in early intervention. The part C, the individuals with disabilities. In case of that, the part C providers, those that basically go into the home and provide those services. So we need 3 wheels to go together. And if I were to tell you that sometimes 50 to 60% of kids get screen positive, never get to diagnosis. And then to get diagnosis, this may happen, a year later. A synaptic grow later, okay? And then to have a diagnosis, but by the time they receive any services, the child is basically getting to school. And that's getting in trouble because they have behavior issues and so forth. So I'm in a hurry here because, the brain doesn't stop. And so here's Jennifer, here's Amy Weatherby, who is the originator of this kind of system that we're trying to deploy in the community. It's something that builds on the family primary care physicians and providers, and it's really a system that combines training with monitoring with public health. The notion of web is a big collection of tools. It's video-based. That child that you saw initially, I'm sure helped you a little bit about what autism looks like at 50 months of age. The vast majority of professionals who have never seen children at that age at risk for autism. And besides, people when they're a little bit wonderful. It's very hard to think about 9-month-olds and 10-month-olds and 12-month-olds who basically are en route to developing autism. So it was absolutely critical to create a training package that capitalized on video so that you could see what's normative at those different ages and what is not normative at those different ages. Collection of tools now is available for physicians and for families and for early intervention providers. We're all speaking the same language. We're also part of an electronic communication system, the ecosystem, as it were. Because one of the big issues is that the moment that child comes to the medical home and is screened, it's very important for us to monitor what happens in the next few months so that that family doesn't fall into the cracks. And it's an opportunity for medical home and early intervention to communicate and with family in such a way really to manipulate. It's really the world that these children are learning about. And so this modality of treatment is using transactional support. We train parents interact with the children in a way that scaffolds that engagement, that basically engineers that engagement. It doesn't sound like very complex, does it? It doesn't sound like a very special. And yet, for us who are involved in Genesis here, for those who are involved in watching what happens to those babies during those months of treatment, is really quite something. This is what it looks like. This is a portal for the Autism Navigator, and all of these incredible resources now are available to families and to pediatricians and to the special private. And the notion here is if you want to reach that intensity, okay, let's use our expert patients, meaning the folks from prevention services, to go home and train the parents on how to deploy those kinds of initiatives. And why? Because they are with their babies every moment of their lives. And so what we can do is truly to use those daily activities that they use all the time in order to intervene and reach that level of intensity of engagement with the child. And so the curriculum does not only involve goals for the child, it involves the goals for the parents. And parents love it. Parents, because many parents of children with autism are despondent because they don't have that reciprocity that most of us have had with our children. So more about that than that time. The notion is that most of all, one is caring. One is creating a way of selling the world with the child and creating that reciprocity that is going to lead to the critically important communication skills that our children need. And if you see, now this is treatment happening in a child's home. What you don't see here is the expert. This is actually behind. This is the mom. And the mom is basically creating a platform that makes it explicit and salient the notion that those important cues in her are of importance to the child. She's making the child basically feel and understand that important things happen in our eyes, and in our mouth, and in our hands, and those things have to make the value. So that's going to, this is a sort of a MTech sort of a glimpse into the kinds of things that we want to achieve in our center. If for somebody who's been in this field for way too many years, I think we're at a very exciting time. There was a field of neurodiversity that I never took seriously for the field of autism until about 10, 15 years old. Because how can somebody say that, oh, this is not a disability, this is just a different way of viewing the world, where the person is running into a wall and it's causing sort of vitiation of their brains because of self-injury. Then diversity, that is a disability. But what we're seeing as we are watching those things go is that this is not autism. Autism is the sense that I come into this world and I have a continuated sense of use. And that's me on a path to developing a whole bunch of things. But that's not autism. Autism is that initial genetic vulnerability associated with social disability. We can live with autism if our children are not intellectually disabled, are not language disabled, don't have so severe behavior child. They have a different style of being in this world. And if you go to Georgia Tech and to MIT and to Carnegie Mellon, you may see a lot of people who have made enormous contributions to the world because they are not disrupted by others. They may actually find other things salient in the world, and it's going to catalyze and channel their energies into something very, very positive. So that's our goal. Our goal really is an aspirational goal, but it's within our reach. To develop this condition from one of profound potential daily disability into one of positive diversity. Because what we want for every child, despite genetic vulnerability, for that matter, despite mental The prevalence is rising. We don't know if the incidence is rising. Starting in the SEALs, we used to say it was 4 or 10,000. Now we're talking about 1 in 68. There are many reasons for the rising prevalence that we know. That's not very exciting. A much broader definition of what autism is, for example, the fact that autism is eligibility. So we don't want to miss children because that confers services. The fact that we now have better epidemiological methods, and we're going into we're sampling. We're now waiting in our clinics. We're actually going to the community by now. And truly the fact that the awareness of this condition has grown dramatically. When I started this year, nobody knew what autism was. Say autism is, autistic children. People say autistic children. They say, no, autism. There are all of those kinds of reasons. Your question is whether or not there is an environmental factor that may be impacting on children. And by environmental, I'm sure you mean not necessarily the placental environment. What you mean is that something in the air or something like that. Well, there is a lot of research these days on those factors. I don't feel that we have come to any conclusions quite this yet, and there are many theories, however. But we're welcome to be cautious about those theories because some of those theories actually can get a lot of people very sort of concerned very quickly. Say, for example, there are some people who mention pollution, or people who mention particular kinds of things that are in our foods and so forth. Those things tend to be generalized, and they tend to impact the whole community. And it seems like autism is more specific than that. But everybody is expecting some kind of gene-environment interaction. I think it's important. This is kind of a paradigm shift. When I talk to my friend Bill Mary, he's very interested in neuroscience outcomes for kids with congenital heart disease, right? To a large percentage, a much larger percentage than you expect of kids with congenital heart disease end up developing autism. When I talk to Barbara Stahl, neuroscience, we talk about the NICU graduates because there's a larger percentage of kids from poor NICU graduates who develop autism. So in the next decade, we're going to have to escape this notion that autism is a disease. Autism is going to be seen a little bit like intellectual disability, a little more like cerebral palsy. There are basically hundreds and hundreds of etiologies that link to that condition. And I expect that there might be some environmental as well of this kind. But we just don't have right now. Sure. So the question is, genetic testing helps. The standard of care nowadays is to have genetic testing. There is a panel of about 46 genes that have been associated with autism, and many of those genes are big hitters. And so that if you have those hits, then you're going to have compromised development. It could be those monogenic conditions like Fragile X, for example, is one of them. There is a whole sort of 28 chromosomes genes in chromosome 7 that are associated with, for example, with this syndrome. And there are many other those syndromes that actually it helps a great deal to know. Some of them have medical implications for future management and things of that nature. The majority of children with autism, however, will not have a particular sort of genetic signature that you can sort of think about as causal because of this polygenic risk profile that is not being associated. And as I mentioned, there's hundreds of genetic factors. At this point in time, the answer is yes. It's sort of care to send blood for genetic analysis at epigenetic class and run the autism panel, as it were, and it can be very, 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 very helpful. However, the yield is still very low in the vast majority of children who do not have a genetic signature. It does not mean that that condition is not genetic. It's just that the genetics is much more complex than could be easily identified. Many people who have been running clinical trials for specific genetic signatures of autism, not only in the coding genes, but also in expression, but nothing really that I can tell you with a clinical value. terrible. Maybe I should ask before you say. Absolutely. Absolutely. It's an important field of science, and we're doing that too. It's called implementation science, and part of implementation science is really health economics. Um, the math is not very difficult to understand. If you ever been to a residential unit, and or there are many residential units for adults, uh, you probably understand that the costs there are huge because those individuals require individual attention all their life, right? And so you start, those things become programs that cost you the fact that, for an adult with severe intellectual disabilities, some order of maybe $100,000 a year for their lifetime. Right? How would you like if I told you, now, you could go back in time of adult life at the time of developing, and other than spending $100,000 a year, we are going to spend maybe $4,000 a year to make possible for that individual to receive this kind of community vital treatment. Would that be a good investment? So that's the kind of thing that we're saying. The purpose of science is that different agencies serve children and individuals at different times of their lives, and we need to come together as a village, as it were, in order to make sure that we do. I think I have not met. The technologist here, geneticists here, help me out here. I have not met a condition that is not benefit from early detection and intervention. I have not. I mean, PKU is probably the best one. I mean, you're going to pay thousands and thousands and thousands of dollars to serve that child and family, or you do universal screening with that baby before that baby leaves the hospital. You change their conditions and off you go. So this is not a feel-good thing. This is we're talking about, I believe, an economic equation that will change, health economics field. That's why I put here, I was both developmental social neuroscience and public health challenge. Right now, we are stupid. I mean, I'll be very honest with you. We are stupid in this amount of center. We are charging government $50,000 to treat children with severe behaviors over a period of several months, because those individuals are basically threatening themselves or threatening others. They are keeping their families in a state of siege at home. So you see, I'm getting the money, okay, in order to treat these children, okay? But I also know that if a child speaks by the age of 3, means that. Okay? This is where I know profit, of course, just like you are. It's stupid. It's like, the medical system wants to, will pay better to put a child in a tube in a hospital than, for example, pay for our feeding disorders program that treats children behaviorally and children not to have invasive speech. There are some real, in health economics, there are some really stupidity. But to answer your question, absolutely. Cost benefit is critical. Cost effectiveness is very critical too. But the health economics is, we're all about that. Because one of the things that we do benefit is that we need to move in the political needle. The political needle is moved when you can say that to make that